Good morning, and welcome to the Optovue Symposium on Changing the Glaucoma Paradigm, Detection and Management with OCT and OCT Angiography. I'm David Huang, the moderator. And I will first make a brief introduction of Optovue, the company. I have been working with Optovue since the very beginning, and the company is all about bringing new technology to ophthalmology. So that begins in 2006 when Optovue was the first company to introduce Fourier domain OCT, which, as you know, was probably the biggest event since the original invention of OCT, making the speed much faster and really laying the foundation for three-dimensional volumetric imaging with OCT and also OCT angiography. In the glaucoma world, Optovue was also the first to introduce macular ganglion cell imaging for glaucoma in 2008. And as you know, ganglion cell complex, or GCC, images the ganglion cells, including the axons, the cell bodies, and the dendrites. And glaucoma preferentially attacks those layers. And by imaging the GCC, you can measure the effect of glaucoma in the macula, and together with the parapapillary nerve fiber layer and the optic disc itself, this gives you a comprehensive picture of structural changes in glaucoma. And more recently, Optovue was also the first to introduce OCT angiography into the clinical world in 2014. And that's based on a fast OCT machine, the 70 kilohertz spectral Fourier domain OCT system, the Avanti, and also a couple of key software. One is orthogonal registration, which get rid of a lot of the motion artifacts, and a very efficient algorithm, the SADA technology, which only requires 2 B frames to compute angiography. And because of this, Optovue is able to get very high signal-to-noise for angiography in relatively short scan time, and still, I think, have the best signal-to-noise ratio. And now also, high-definition OCT angiography has been introduced, which give you a lot more detail. And the special algorithm, split-spectrum amplitude decorrelation angiography, or SADA, is based on the insight that OCT angiography detects speckle decorrelation or variation caused by movement of blood cells. And speckle differs in different wavelength. So you can have wavelength division splitting of the OCT image to get up to 11-fold increase in information without any increase in scan time. So it's very efficient. And this allows detailed OCT angiography images from which you can detect the vessel capillary dropout in the macula in the superficial layers and also around the optic disc in the radial capillaries. And you'll hear talks that describe how this can help with diagnostic accuracy. This is very repeatable to measure vessel density, and it tends to have very good correlation with visual field, which I think in the future will be important for monitoring of glaucoma. And I like to give you a plug for a conference that I'm holding on this topic in the very near future. So without further ado, I will introduce our first speaker. Our first speaker will be Dr. Qianyuan Zhou from Optovue, and she will talk about the latest and upcoming development in Optovue, OCT and OCT angiography technology. Let me give a brief introduction to Dr. Chen-Yuan Zhou. She holds a PhD in biomedical engineering from the University of Miami and has 20 years of experience in the ophthalmic imaging device field. And she joined Optovue in 2010 as Vice President of Clinical Affairs and Clinical Development. Dr. Zhou?
Thank you, David. Thank you for the introduction. Hi, everyone. Welcome to this symposium so early in the morning. And I will go into providing a brief update on the software development at the Optovue. So that's already. So following last year's software release on dual track for OCTA scan acquisition, recently Optovue released the AngioView HD scans. That's a scan of 400 by 400 A scans per volume. With this scan, the vasculature details are better visualized as shown in the examples here. On the left is a normal eye, on the right is a glaucoma eye. This is a 4.5 by 4.5 millimeter scan, and you can see the details of the radial peripapillary capillaries features, and in the glaucoma eye, you can clearly see the reduction of this capillary layer. So everybody is quite familiar with OCTA projection artifacts, and that's common to all OCTA scans. At Optovue, we have recently developed a 3D projection artifacts removal algorithm that removes projection artifacts from all layers, as shown in the example here. On the top row is the original OCTA volume, 4 en face images, superficial, deep, outer retina, and the choroid capillaries. And at the bottom row is the projection artifacts removed images. And as you can see in the deep plexus, outer retina, and the capillary, the projection from superficial plexus are removed. These are particularly important for diabetic retinopathy evaluation of the deeper plexus and for wet AMD and macular changes in the outer retina and the choroid capillaries. And previously we had 2D projection artifacts removal for the outer retina. This example showing from original volume to the previous 2D PAR and now to the 3D PAR. With the 3D PAR, the artifacts are removed while the original the CNV signals are better retained, and the connectivity of CNV vessels are better maintained. Did you go down this one? So we also developed new 8-layer retina segmentation. The main reason for that is we actually needed the more boundaries to better define the en face slabs for OCTA image interpretation and quantification, particularly the outer plexiform layer and the Brooks membrane layer, which previously did not exist in our software. And the processing time is pretty fast. It's less than 7 seconds for the high density volume. And with the addition of OPL and the Brooks membrane, we can better actually provide the deep vascular complex definition from IPL to OPL. Previously, is using IPL only with offset. And we can also provide a custom slab, which provide flexibility to visualize individual plexus. And also for the outer retina, we actually provide the OPL to Brooks membrane that's a consistent basis for CNV evaluation. So in the coming software, we will update some of the en face slab definitions to be somewhat modified from the previous software versions to better match the vasculature definitions as described in the recent paper by Dr. Huang and the OHSU group. So for the superficial, we will go from IOM to IPL slightly shift anteriorly 10 microns, which corresponded to the superficial vascular complex, SVC, as described here. And then for the deep, we will actually combine the so-called intermediate and the deep vascular complex, DVC, as deep from IPL to OPL, slightly posterior OPL, as shown in this slide. So with the custom layer, we can further divide. User can select the boundaries, and for example, you can further visualize the intermediate plexus or the deep vascular plexus, like these examples here. The one very nice, I think, a consistent basis for CNV visualization is from OPL to Brooks membrane. These are 3 examples showing very different B-scan appearances, but using the same boundary definition from OPL to Brooks membrane, you can visualize different CNV types and all this like a complete CNV net. And with the 3D part, the projection artifacts is also removed from the B scans. Therefore, the in situ CNV signals can be visualized in these B scans. Like in all automatic segmentations, in pathological cases, there will be difficult cases that segmentation could fail. Like this example, Brooks membrane in the top row showing there's some segmentation error in the Brooks membrane layer, and by modifying, we have developed this segmentation editing and the propagation tool. By modifying a few B scans, then propagate through the entire volume, you can get that entire volume Brooks membrane corrected. And the bottom row shows the example of after correction, the OCTA on-fast images that showing the complete CNV net, and on the right showing the corresponding updated thickness from OPL to Brooks membrane. So we believe this will be useful to researchers to produce more accurate results. We also developed quantitative analysis. Previously, we had quantitative analysis for the retina scans, but now we are actually providing for the disc scans as well. And because the OCTA volume contains both the vasculature information and the structural information, so we actually aim to provide both sets of analysis from the same scan. So you can get density analysis on the RPC layer. You can also get nerve fiber thickness, disc, and the cup parameters from the same volume. And the BMO is automatically detected with our software, and the cup and the rim assessment with the coming software is going to be based on the BMO plane. And here's a new report screen with the next software release, showing on the same screen the vessel density and also the thickness measurements. And here's an example of a retina scan quantitative analysis showing the vessel density analysis superficial at the bottom left, and also the ganglion cell complex thickness, the second image, and also the full retinal thickness all the way to the right. And this is actually not implemented yet. It's a mock-up report. We plan to provide the trend analysis. So basically showing trend OD, OS, both eyes, and showing superior hemifield, inferior hemifield, and also global change over time for vasculature. We can also provide these for the structural parameters. And these are examples of the information you can get from a single OCTA volume. it's a glaucoma example. The top is the moderate glaucoma case, and the bottom row is an advanced glaucoma case. Basically, you can get the intensity image, which shows the loss of a nerve fiber layer from refractivity point of view, and the RPC layer on fast image is showing the vasculature dropout, the capillary dropout, vessel density of this layer, and also thickness of retinal fiber layer, and also carbon disc measurements. And going forward, for the quantitative analysis, we recommend the following scan patterns for research and for clinical use: 4.5 by 4.5 HD scans, disc scan, and 6 millimeter HD retina scan for glaucoma, and for retina also the 3 by 3 millimeter angioretinal regular scan pattern. Thank you for your attention.
Oh, I should have turned it on first. Let me say again. I was just saying that accurate segmentation, projection artifact removal, and quantitative measurements are very important for both glaucoma and retinal applications. So this new software is going to be a really big step forward for the clinical application of OCT angiography. Now, because we want to present a lot of information within an hour, so we're going to hold a question until the end. We have this room for a long time, so we can have an extended question and answer sessions at the end. Our next presentation will be given by Dr. Ted Garway-Heath, and his topic is glaucoma case findings with iView OCT. And let me give a brief introduction to Dr. Garway-Heath. He's the professor of ophthalmology at the Institute of Ophthalmology, University College London, and head of research in vision assessment and imaging at Moorfields Eye Hospital in London. A focus of his research is on the development and evaluation of the techniques for effective diagnosis, monitoring, and management of glaucoma. Ted?
Great, thank you very much for the introduction. So this talk is speaking to the diagnostic capabilities of OCT for glaucoma. The title has subtly changed in that we're talking here about case finding rather than screening, and I'll explain why that is in just a moment. So by way of financial disclosures, I have research support from companies who make imaging devices. So this is the point about the difference between case finding and screening, and really the difference is the environment in which you're looking for the glaucoma patients. So case finding is usually opportunistic and might occur in primary care, whereas screening is often when you go out into the population to look for glaucoma cases. The critical difference really is the prevalence of disease. So in screening, you might have a prevalence for glaucoma of around 1 or 2%, but in a case-finding scenario, often the prevalence is a bit higher. And I'll show you some slides to illustrate why that's important. But irrespective of whether you're case-finding or screening, you need an instrument that has fairly rapid data acquisition and also a high success rate in obtaining data from patients, and that's something that's often not reported. But for glaucoma case finding, the real problem that we have to deal with is the false positives, and the following slides will show why that's potentially a particular problem. So if we think of the general population and be generous with an estimate of prevalence and say it's 3%, and we take a test that might have these sorts of diagnostic performance, so a 5% false positive rate, so specificity of 95%, and a 70% sensitivity. We can look to see how that performs in case finding in the population. So if we have a 3% glaucoma prevalence, that means 97% is healthy, and we only have 3 out of the 100 with glaucoma. Now we have our 5% false positive rate applied to these 100, and this will give us about 5 false positives from this 100. If we have 70% sensitivity on a 3% prevalence, it will pick up about 2 of the 3 glaucomas that are present. And that means out of all the positive test results, only 2 out of the 7 positive test results will actually have glaucoma. So it's a 28% post-test probability. And we can usually use something like this, which is the Fagan nomogram, to illustrate this sort of idea. The pre-test probability here, that's the prevalence. The likelihood ratio for the case I showed you is about 14, and that gives a post-test probability of 28%. And I'll refer back to this sort of diagram shortly. So when we're thinking of case finding or screening, we need to, first of all, decide whether or not it's worthwhile. And it's obvious in glaucoma that it is worthwhile because it's an important cause of blindness. There's a lot of glaucoma that's undiagnosed, and we know that late diagnosis is a risk factor for glaucoma blindness, and we have treatments which work. So finding glaucoma early will prevent unnecessary blindness. So what are the candidate tests for case finding? Well, we could look at intraocular pressure, but we know that that's only a risk factor and not the disease. But it does raise the probability that glaucoma might be present, so it does have some utility. For perimetry, we have problems of a learning curve, high false positive rates in patients doing the test for the first time, and it's a more time-consuming test. So OCT is an obvious better candidate. So in a technology evaluation, which the study I'm going to present in a moment is, we need to do it in the circumstances in which the test will be applied in the real world. So we need to do it in primary care. Often in primary care, we've got patients with comorbidity, and that can raise the false positive rates. And we need to be avoiding what we call red disease, which is clinicians looking at printouts that have got red patches on it and saying, well, that must be glaucoma because the printout's got red on it. We also, in these sorts of studies, need to think about the patient rather than the eye that we're looking at. So we give the diagnostic performance of the device at the level of the patient. So in this particular study, we asked the question, can OCT imaging be used for case finding in the community? It was a prospective cross-sectional study based at a university but community-based eye clinic. We looked at men and women over 60 years, so a relevant population for glaucoma case finding, and there were no exclusion criteria, so we looked at everybody who walked through the door. The technologies we evaluated were the iView, the Aura ocular response analyzer for intraocular pressure, and 2 vision function tests, the Moorfields MDT and the FDT1. So these are what we call the index tests. So for perimetry, you had FDT1 with the C25 program, Moorfields MDT. The technician taking the pictures was unaware of the diagnosis of the patients in front of him, and the order of the vision function tests was randomized, and they were repeated if they were abnormal. For the iView, we used the GCC, the ganglion cell complex measurement from the eye wellness scan, and then the nerve fiber layer thickness measurements from a peripapillary circle sweep. And the thresholds for abnormality were pre-specified in the analysis ahead of time. The reference standard was an experienced clinician looking at the patients with Humphrey perimetry, Goldman tonometry, and a slit lamp examination of the optic nerve. She had no knowledge of the results of the index tests, and she divided the patients into those that had definite glaucoma, who had nerve and field loss, glaucoma suspects, which had either, and ocular hypertension or normal subjects. This is a breakdown of the patients. So 505 patients, no exclusions. The technology is evaluated, and this is the diagnostics classification of the subjects, and we had 5% of the population that actually had glaucoma. Just to highlight a couple of features of the population, the healthy and the glaucoma patients had roughly the same age, late 60s, and this is the amount of glaucoma, so the glaucoma patients had a mean deviation on average of -9. Now, importantly, as I mentioned at the beginning, we need to know what proportion of the population we can successfully get test results in. And for the OCT, we were way up around 96, 97% of patients we could get good quality exams. And these are unselected patients walking through the door. So that's a good feature. If we look at the diagnostic performance, this is if we put the glaucoma patients and suspects together, and we're looking at the 90% specificity level, so 10% false positives. We can see that OCT picks up between 55 and 60% of the open-angle glaucoma and suspect patients, and this does better than the visual function devices. But more relevant is looking at the patients who have manifest glaucoma, because that's what's important for potential blindness. The OCT detected well over 80% of the patients with glaucoma, which is better than the visual function tests. Now, this is a bit of a busy slide, but I'll just highlight two of the criteria for diagnosis from the OCT. That's the nerve fiber layer thickness in the inferior quadrant. That was the best nerve fiber layer thickness parameter, with a likelihood ratio of 15, and then the ganglion cell loss variance with a likelihood ratio of 21. If we apply that to our population, 5% we knew had glaucoma at baseline. After the test, the post-test probability improves to between 40 or just over 50%, just on the basis of either of those OCT parameters. So this is something that's very useful for refining the likelihood of glaucoma in patients in front of you. We can combine test results, and if we combine the OCT results with the visual field and intraocular pressure results, we can get to a post-test probability of better than 85%, but if we do this, the sensitivity is a bit lower. So to conclude, OCT imaging has an important place in glaucoma case finding. It's applicable it's applicable to most subjects in the community. Over 97% we could get pictures from. An abnormal OCT scan significantly increases the likelihood that glaucoma is present, and then we can combine the results with other test results. Thank you for your attention. We'll be taking questions, as David mentioned, at the end. So I'll move straight on to introduce David, who's our next speaker. He's Professor of Ophthalmology and Biomedical Engineering at Oregon Health and Science University. He did his MD at Harvard University and PhD at MIT, and most relevant, I think, for the topics here is that he's a co-inventor of OCT technology. And he's going to be speaking to us now about prediction and detection of glaucoma progression with OCT. David.
Thank you, Ted, for the introduction. So I do have financial interest in OCT and OCT angiography technology with regard to Optovue. So I'm going to speak about results from the advanced imaging for glaucoma study. This is a study that's funded by the National Eye Institute in the United States for technology development, and it also includes a multi-center prospective observational study of three groups of subjects: parametric glaucoma, glaucoma suspect and pre-parametric glaucoma, and normal reference control. It's a moderately large study with 3 centers, follow-up up to 9 years in some cases. The normal subjects will follow every year, and the patients will follow every 6 months. And this study used Fourier domain OCT, specifically the Optovue OCT system from Optovue, and it measures 2 scans, the optic nerve head scan, which gave us disc parameters as well as nerve fiber layer map, and a macular scans that provides ganglion cell complex map. As you may remember, ganglion cell complex is abbreviated GCC, and it includes the nerve fiber layer, ganglion cell layer, and inner plexiform layer. And these 3 layers are primarily affected by glaucoma, while the deeper layers of the retina are relatively spared. And we have known this since 2009 when we described this entity. And there are many parameters we can derive from the map, but I want to bring your attention to one parameter specifically, which turned out to be very important for predicting progression and conversion, and that's ganglion cell complex focal loss volume. And to get this parameter, first we obtain a pattern deviation map, and that's a percent deviation from normal of a map that has been normalized to the normal thickness map. And those areas that are abnormal are areas of focal loss. And in those areas, we then measure the volume of tissue loss, again, relative to the normal average reference. So first, predicting glaucoma conversion. These are patients in the suspect and pre-parametric glaucoma group who had normal visual field at the baseline, who subsequently developed abnormal visual field on 3 consecutive visits. So it's a fairly reliable measure of someone who developed parametric glaucoma during the study. And we found that the one parameter, ganglion cell complex focal loss volume, was the best predictor of visual field conversion out of all the OCT parameters. So eyes that have borderline or abnormal GCC FLV actually have more than 3 times the chance of converting during the duration of the study. So it's a very important parameter to look at in your pre-parametric glaucoma group. We also look at all the OCT parameters in general, and 82% of visual field conversion was preceded by abnormal OCT. So OCT is generally fairly predictive. And there was a 23-month lag between visual field conversion and the initial OCT abnormality that was detected. So by using OCT, you can detect early glaucoma at an earlier time. Next, I want to talk about predicting glaucoma progression. Now, this is analysis done in the parametric glaucoma group. And this group had the median follow-up of 52 months. And this is published in AJO in 2016. And out of this cohort, 83 eyes progressed during the follow-up period. And progression was based on one GPA event analysis, or the 3 black triangles test, and a significant negative visual field index slope. And the Venn diagram in the bottom show you that the trend analysis was more sensitive for picking up progression in this group. Now, many baseline factors were significant predictors, including central corneal thickness, which we knew already from earlier, visual field parameters, and a number of nerve fiber layer and ganglion cell complex parameters. And again, GCC FLV had the highest predictive accuracy. So eyes with, again, borderline or abnormal GCC FLV have about twice the risk of detectable progression during the follow-up period. So it's important to look at the GCC to assess the risk of progression. And it is predictive of the rate of progression as well. So as you can see here, eyes that have abnormal GCC FLV tend to progress much faster in terms of VFI slope. And finally, I want to talk about detecting glaucoma progression in both the parametric glaucoma and the suspect and pre-parametric glaucoma group. This group had OCT and visual field tested every 6 months, and we selected those eyes that had at least 5 visits so we can perform trend analysis. And this is a typical example where we did trend analysis by linear regression and detected progression earlier with the OCT parameters because there's less variation compared to visual field VFI or MD. So in the suspect and pre-parametric glaucoma group, there's a lot of numbers here, but you can see that we look at trend progression for both GCC and NFL and combine them with either OCT test. And in visual field, we look at 3 types of progression analysis. And the most important takeaway here is that with OCT, progression was detected in about almost twice as many eyes, and specificity was comparable between the 2 methods. So in visual field, MD, mean deviation, actually worked best in this very early group. And nerve fiber layer and GCC were both important with moderate overlap. And comparing OCT and visual field, OCT was far more sensitive in picking up progression in this early stage of the disease. Now let's look at the parametric glaucoma group. So this group at the baseline already have an abnormal visual field. And here you see that both mean deviation and visual field index perform about the same. GCC tended to work a little bit better. And again, we found even in parametric glaucoma that OCT was able to detect progression more often. So again, OCT was able to detect progression more often, and this was significant in the mild parametric glaucoma. Now, nerve fiber layer does have this floor effect in that in advanced glaucoma, it tends to track progression less well because it had reached a very thin value that doesn't change as much anymore. But you notice that we didn't see this floor effect in GCC, in the macula. It continued to follow glaucoma well into the advanced stages. And by using both nerve fiber layer and GCC together, it continued to outperform visual field. And this is a Kaplan-Meier curve showing that the visual field and OCT detection are significantly different. OCT being able to detect progression about 2 years earlier in the GS-PPG group, and by 1 year earlier in the parametric glaucoma group. So in conclusion, OCT detects structural damage 2 years before visual field damage on the average, and it detects progression 1 to 2 years earlier compared to visual field, depending on the severity of disease. And OCT structural damage in general is a strong predictor of visual field conversion and progression. And GCC FLV is the best predictor in this study. In terms of progression detection, both nerve fiber layer and GCC outperforms visual field in early glaucoma, and GCC continues to detect progression well into advanced diseases. I'd like to acknowledge the Advanced Imaging for Glaucoma study group, many collaborators. Thank you. So our next presentation will be given by Professor Natalia Kurisheva. She will speak on AngioView OCTA in early glaucoma detection and monitoring. And let me get to my cheat sheet so I can give a brief introduction. So Professor Kurisheva is head of Diagnostic and Laser Treatment Department at the Federal Medical and Biological Agency of the Russian Federation. Her field of scientific research is glaucoma, and more specifically, ocular blood flow, normal tension glaucoma, pseudoexfoliation syndrome, as well as laser and surgical treatments. Natalia?
Thank you, David, for introduction and the invitation. Dear colleagues, it has been recognized recently that evaluation of structural changes using OCT has a very high accuracy, both for early glaucoma detection and its monitoring. First of all, it refers to retinal nerve fibrillary and retinal ganglion cells in macula. Why does macula attract our attention so much? Not only because of high concentration of ganglion cells here, but also because of the existence of macular vulnerability zone that has been described recently by Donald Hood. This area spreads from the inferior temporal macula to the temporal inferior part of peripapillar retina, and it has been assumed that this area is very sensitive to ischemia and reperfusion. However, this assumption hasn't been proved yet, and it determines the importance of ocular blood flow evaluation in glaucoma. Many different methods have been used in order to answer the question whether vascular changes are a primary or secondary consequence in glaucoma. For example, recently, using color Doppler imaging, we revealed a very high diagnostic ability of some parameters of CDI in detection preperimetric glaucoma, especially venous blood flow. But you know that CDI doesn't allow to measure microcirculation of retina. Therefore, the appearance of a new method, OCT angiography, has raised once again the question, does blood flow measurement have a role in glaucoma care? This method is based on split-spectrum amplitude declaration algorithm that has been introduced by a group of David Huang, and it allows to measure vessel density both in optic nerve head and peripapillar retina divided into sectors and quadrants according to grid-based algorithm, and in macula, in fovea and parafovea also divided into sectors and quadrants in superficial and deep retinal plexuses. Interestingly, that recently some new plexuses have been described, it has been covered today already, and the amount of papers on OCT angiography in glaucoma is growing each month. The first paper was published by the author of this method, who revealed the very significant decrease of vessel density and blood flow in optic nerve head in early glaucoma compared to normal eyes. Later, some other authors revealed the link between the parameters of OCTA in optic nerve head and the severity of glaucoma process. The first multi-central study was conducted by the American authors, who revealed the stepwise dropout of vessel density in optic nerve head and peripapillar retina, the parameter so-called hole-in-face image, from the normal eyes to glaucoma suspects and severe glaucoma. And some other groups confirmed these results and pay attention to the importance of the evaluation vessel density in the inferior part of peripapillar retina. The group from California recently has reported about the very high diagnostic ability of papillary vessel density in detecting the preperimetric glaucoma. Much attention is paid to the preliminary part of optic nerve head, and some groups reported that the vessel density in the preliminary part of optic nerve head was the only one parameter for discriminating between the ocular hypertensive eyes and normal eyes. The question is, does vessel density depend on IOP reduction? According to Professor Gola, a significant decrease of IOP may improve vessel density in peripapillary retina. But this opens another question. Do we need to stop the administration of a hypotensive eye drop before the examination? Personally, we did this in our study, in our research, and 1 year ago we published our first paper where emphasized the importance of the evaluation of macular vessel density in macula in early glaucoma detection. So we compared the patients with early glaucoma, advanced stages, and normal eyes, and we measured 225 clinical parameters in each eye. Some of them are summarized in this table. So we measured mean ocular perfusion pressure, we used aura, we measured peripapillar and measured the choroidal thickness in different points, and we also used electrophysiological testing. We measured visual evoked potentials and pattern EIG in our study. So, and we revealed the significant decrease of vessel density both in macular area and in optic nerve head and peripapillar retina. And in these graphs, you can see the cutoff indexes that we determined in order to discriminate between the early glaucoma, normal eyes, early glaucoma, and advanced stages of the process. Like other authors, we revealed the link between the reduction of vessel density in peripapillar retina and functional loss. But for the first time, we detected the correspondence between the vessel density in peripapillar retina and visual evoked potentials parameters, as well as between the dropout of vessel density in superficial macular area and the parameters of pattern EIG in a healthy and glaucoma, early glaucoma eyes. Only in early glaucoma eyes we revealed the correspondence between the structural changes, especially in GCC and GCC parameters in the inferior GCC and the vessel density in the superficial macular area. In these clinical examples, you can see the correspondence between the dropout of vessel density in peripapillar retina, functional loss, and structural loss. But it was especially visible in the advanced stages. In regard to early glaucoma detection, it was macular, where the dropout of vessel density was clearly shown at the very beginning of the disease and even preceded structural and functional loss. Along with parameters of pattern EIG, the vessel density in superficial macular area had the highest diagnostic ability, even more pronounced than in average retinal nerve fiber layer thickness. In contrast to our data, Indian authors recently has reported about the priority of the evaluation of vessel density in inferior temporal peripapillar retina over macular area in early glaucoma detection. But we explain this by the more severe glaucoma process in patients recruited in this study compared to our glaucoma patients, because it really depends on the stage of glaucoma process, on the severity of the glaucoma process. And when we compared the stages, the early glaucoma, the advanced stages, we paid attention that inferior temporal vessel density, peripapillar vessel density, had the highest diagnostic ability, along with structural variables. In conclusion, OCTA is a very perspective method for early glaucoma detection and its monitoring. And besides, we believe that this method will help us to better understand glaucoma pathogenesis in future. Thank you very much for your attention.
Thank you, Natalia. Our next presenter is Dr. Linda Zangwill, who will talk about AngioView OCT angiography in glaucoma research. Dr. Zangwill is a professor of ophthalmology in the UC San Diego Department of Ophthalmology Shiley Eye Institute. At the Hamilton Glaucoma Center, Dr. Zangwill serves as the Director of Clinical Research, Diagnostic Imaging Laboratory, and Idea Reading Center.
Thank you. My slides, please. Thank you for the invitation, and I want to apologize. I'm in another session at 8:30, so I think we decided I'll take a question or two after my presentation, but then I'm gonna have to run. This one? No, this one we order. I want to acknowledge my financial disclosures. So we heard a little bit about OCT for glaucoma management, that the assessment of the microvasculature of the optic nerve head, the macula, may be useful in the diagnosis, staging, and monitoring of disease. But the unanswered question is, does OCTA provide important additional information over standard optic nerve head and macula OCT images? I think we heard some results that show yes, and some results that it's similar to nerve fiber layer for detecting glaucoma. So I'm not sure, and I'm not a clinician, about how much it will be used for clinical management, but I'm convinced that the OCTA will be critical for improving our understanding of the pathophysiology of glaucoma. Glaucoma, as we heard, is characterized by retinal ganglion cells and their axons. Both vascular and mechanical factors play a role in the pathophysiology of glaucoma, and it's not clear how often retinal vascular changes precede retinal ganglion cell and axonal loss, or vice versa. As we heard, is the vascular changes the primary or secondary event in glaucoma? We're not sure. I think probably in some people it might be more of a primary event, and others it might be more of a secondary event. I think there's going to be a lot of individual variability in the presentation and progression of the relationship between these two. And I really believe that OCTA now, with this new technology, will be able to get a better handle on these issues. So here's a case. The top row is a healthy eye. We can see the choroidal layer now with the new projection artifacts resolved. We might be able to see this more often. The nerve fiber layer, superficial macula, nerve fiber layer thickness. We don't see signs of damage. On the second row, advanced glaucoma eye, happens to be a high myope, peripapular atrophy you see, choroidal layer, you see the tortuosity of the vessels. You see clear vascular dropout in the areas where there's a nerve fiber layer defect on the far right column, and you also see the macula where there's sparser vessel density. I'm going to focus a little bit on my talk on the radial peripapular capillaries, which supply the retinal ganglion cells and their axons. They are selectively damaged in glaucoma, and we've known this since the 1960s, but now we can really visualize it with this technology. And there's several reasons why the RGCs are more vulnerable. They might be because of the loss of perfusion from the local radial peripapular capillaries, which are located in the nerve fiber layer in the optic nerve head. There's also biomechanical properties of the lamina cribosa, which probably are affecting these capillaries and retinal ganglion cells. And they're also affected by IOP changes, likely due to their small diameter, extended length, and superficial location. And the radial capillaries have been shown in experimental glaucoma models to be susceptible to injury by IOP. And we know in humans now with Dr. Hollow's work that we already saw earlier, was that when you have a medical reduction in IOP, you can see a reduction in the vessel density using this technology. So I think that OCTA will provide critical data on whether vascular changes are a primary or a secondary event in the pathogenesis of glaucoma. So what we're going to be needing are longitudinal studies. We're going to be following glaucoma patients, seeing who's progressing, and seeing whether we're seeing in that progression microvascular dropout first, retinal ganglion cell or nerve fiber layer dropout first, or dropout at the same time. And I think it's going to be a mix. If you're having glaucoma suspects developing glaucoma, is that vascular event detectable first? Or is it nerve fiber layer, ganglion cell, or at the same time? And also aging changes. We know now that we see nerve fiber layer thinning with age. How often are we going to be able to see vascular dropout with age? Is that going to be more detectable sooner than nerve fiber layer? We don't know. But what I think is most importantly is this is going to be not one or the other. There's going to be a lot of individual variability. Perhaps people with systemic disease and diabetes, it'll be more of a vascular insult. Perhaps people with high IOP and a large disc, it might be more of a mechanical insult as the primary event. And I think all these covariates, all these other factors will be able to get a handle on this. Here, in terms of progression, I'm a skeptic by nature, but this is one case we're only followed for a year. We see superficial dropout in the macula. It's a little bit variable, but we didn't see any change in the ganglion cell or the nerve fiber layer, particularly in this particular case. When we looked at 3 groups, small number of eyes, short follow-up, but in the healthy eyes and the suspect eyes, we did not see a change in the microvascular dropout. Only in the glaucoma eyes do we see a significant change, and this is in less than a year and a half. In this particular cohort, we were not able to see a ganglion cell complex change. So this is interesting, and I think that this will really be helpful in understanding the pathophysiology of glaucoma. I think we're also going to be looking at the relationship between vascular and mechanical factors. Here's an eye without a lamina cribrosa defect. We don't see vascular dropout, and we see a focal defect in the nerve fiber layer. Case 2, we have a focal lamina defect. We see microvascular dropout, and there's evidence a little bit of a focal defect, but not much, just case studies. But what we looked at, we had 41 glaucoma patients with lamina defects, 41 without, and we tried as best as we could in this small group to match for the severity of visual field damage and nerve fiber layer thickness. And what we saw was the vessel density was significantly lower in the glaucoma eyes with focal defects compared to those without, and they were spatially correlated with the location of the defect. The bottom solid line there are the eyes with the lamina cribrosa defect. So you could see that the vessel density was lower in those eyes. Moreover, in 71 eyes with peripapular atrophy, we saw deep layer microvascular dropout in 52% of those eyes. Using the OCTA choroidal vessel density maps. In the area of the peripapular atrophy, there were no projection artifacts. And what we found was that the deep layer microvascular dropout was associated with lamina defects, more advanced glaucoma, reduced nerve fiber layer thickness, thinner choroid, and lower diastolic blood pressure. So it's a complicated story. Once again, we need longitudinal studies. This is a gross oversimplification. There are so many properties of the lamina, stiffness, strain, et cetera, pore size, but just for an example, we can have longitudinal studies with lamina defects, without, and follow them and see the relationship between the vascular and mechanical factors, and also the relationship with PPA. So for research, I think the OCTA will provide critical data to improve our understanding of the pathophysiology of glaucoma, whether vascular changes or how often vascular changes are a primary, secondary event, relationship between the vascular and mechanical factors. I think in patients it's probably not one or the other, but a mix, but in some patients it's probably more mechanical, some patients more vascular. Relationship between changes, microvascular changes and peripapular atrophy. There's going to be a lot of individual variability. I think we're going to need large sample sizes, and perhaps it might be even establish new endpoints for clinical trials and new therapeutic targets that if we can monitor the vascular changes for clinical trials. Thank you very much, and I hope everyone's been able to catch Helsinki at midnight. This is not midnight.
Are there questions for Dr. Zangwell from the floor?
Yes.
You mentioned about diabetes, but you haven't mentioned about hypertension. So in hypertension, when you have narrowing of the microvessels, does the vessel density change, and does that affect what you see on the superficial plexus or on the deep plexus on an OCT?
Yes, no, when I said diabetes, I should have also mentioned systemic hypertension. We have not looked at that. I assume with the constriction of the vessels, it will be picked up. In the retina, I don't know that there's any, maybe someone else in the audience could help me out there. If there's studies on that, I would assume it would affect the vessel density, and that's probably part of the story as well.
And because there's going to be comorbidities, it's going to be probably even more difficult.
Could be, it could be. It's going to be challenging. You're going to need a lot of patients with different types of systemic disease and different phenotypes in the disc.
Okay.
Is there something like a minimum amount of vasculature that you've got to see to say that this is normal and this is abnormal, or is it just a visual kind of comparison between normal and dropout?
I think they're working on a normative database for OCTA. Is that true? I don't think there's true normative limits yet. There aren't normative. I assume that's in the works down the road sometime.
Thank you, Linda. We'll take that as a first question, but let's get Dr. Gabor Hollow's presentation first. Sorry about that. Dr. Hollow will talk about the role of Optovue OCTA in the management of other optic nerve disorders. Dr. Hollow is a director of glaucoma service and perimetry unit in the Department of Ophthalmology at Semmelweis University in Budapest, Hungary. Thanks.
So welcome everybody. Actually, that's a good question. I'm happy to answer it at the end. And in contrast to yesterday when I was speaking about glaucoma and I was showing a lot of research results, publications, and so on, today I was asked to speak about various optic nerve head diseases, and I'll be very practical. These are my financial interests. So we all know, and I'm not going to get into details, that this is the group of information pieces we have: the OCTA results, the measurements, whole image, sectors, peripapillary area inside the disc, retinal nerve fiber layer, enhanced images, measured OCTA values, the color-coded map to help us to orientate ourselves, GCC, retinal nerve fiber layer, TSNIT, graphs for comparisons. This is a group of information which can be used for all optic nerve head diseases for better assessment. But first of all, please note that just because we all like glaucoma and we all work on glaucoma, there is no obligation for any eye to show glaucoma or to have glaucoma and not other optic nerve head diseases, which are also there and which should be actively and cleverly ruled out and separated from glaucoma using conventional clinical methods. This is just an illustration for that. You don't see too much differences across the GCC maps, the retinal nerve fiber layer thickness maps. Even if one is a non-glaucomatous optic nerve atrophy, the other one is a compression problem due to optic nerve head drusen, and the third one is an advanced glaucoma case, no difference. In any cases, wherever you have retinal nerve fibers, you will have OCTA measured perfusion. This is an advanced glaucoma case. This is the papillomacular bundle which survived. You can see the dark areas are missing nerve fiber bundles, and some inferior nasal parts of the retinal nerve fiber layer is also maintained. And then when we go on qualitative OCTA measurement, we do see a much more dense network of OCTA signals in these areas where the retinal nerve fibers are maintained, in contrast to all other surrounding areas where most of the retinal nerve fibers have been lost. But this is not just glaucoma, but a lot of other things. This is optic nerve head decoloration due to an earlier non-arteritic anterior ischemic optic neuropathy on the right eye. You can see, obviously, the differences in particular for the temporal retinal nerve fiber layer. And when you go to the OCTA images, this is the superficial one, and this is for the retinal nerve fiber layer. You do see, in contrast to the healthy left eye, that this is a dark area. Of course, this is the layer where we pick up the optic nerve head signals, and in the retinal nerve fiber layer in the diseased eye, you do not see anything, just the noise, in contrast to the healthy structure on the other eye. And if you move to the, let's say, to the overview of the case, you can follow the same things for the OCTA, same for the enhanced OCT imaging, the OCT map, which is very bluish, which means there is no signal, and the corresponding visual field. What about if this disease is in an acute phase? The issue is a bit more complex in this case because you do see a lot of edema, not surprisingly, and you do see that the perfusion signals with OCTA are not picked up in that area. Currently, at this stage, we cannot tell whether this persists over the acute phase and will be turned to a chronic decoloration and loss of fibers, or this is just a temporary issue when the acute problem is just on. What about retinal vein occlusion? This is a nice case of a patient who is one eye glaucoma patient due to pigment glaucoma. This eye has pigment dispersion, but this is not why I'm showing it, but because of the typical non-ischemic retinal vein occlusion. You can follow, these are the en-face OCT images, some macular edema, and you can follow the tertious vessels. And at the same time, when you use the OCTA method to evaluate, you see the same and at the same time somewhat lower density of capillary signals in the retinal fiber layer. And this is the corresponding en-face and OCTA images. You can see, you can follow the chronic edema there. A very interesting point is retinal nerve fiber layer and disc hemorrhages in glaucoma. This is very funny because we don't know that there are nerve fiber bleedings in the retinal nerve fiber layer, like this one, and we have deep disc bleedings, which are not so well defined and sharp, but they are there and they also indicate progression. If we go like this, if we go for the well-known superficial nerve fiber bleeding, and you go to this case, you do not see any change on the OCTA. Why? Because the blood is there, but the blood is not moving, so there is no moving signal, though it is not picked up with the OCTA, but it does detected by the en-face OCT images, and you can see that this is next to the most importantly and most severely damaged bundle. This is very typical. But what about this hemorrhage-like stuff? In fact, it turns out that this is not hemorrhage. This is an aneurysm on the bottom of the disc, and since I've been using OCTA, I did find a lot. Otherwise, they are not visible on the en-face images, and this method is excellent to separate deep lamina cribrosa bleedings from lamina cribrosa embedded aneurysms. Another funny thing is that for glaucoma, I think I was the very first who published a case series on the fact that as it was shown in the previous talks, that the OCTA-derived peripapillary angular fluid density decreases prior to the significant thinning of the retinal fiber layer. And on the other hand, we found a lot of cases which I so much like. These are myelinated nerve fibers, which are a natural model for very many things. These are the myelinated fibers. You do know that in the eye normally there are no myelin sheets, but when they are there, they represent an extra volume, and this extra volume pushes the nerve fibers typically towards the vitreous body. And what you do see here, you can see this part. And this is the comparison between the two healthy eyes. You can see that the measured so-called thickness, but it is not retinal fiber there, this is everything, is higher here. And you do see that in the superficial layer, close to the vitreous body, shows an increased vascularity in the area of the myelinated nerve fibers, and in the retinal nerve fiber layer thickness, the vascularity, the signals are much smaller. This is nothing else but a space shift towards the vitreous body, and this natural model shows that segmentation with OCTA works brilliantly in such cases. This is another case with exactly the same findings. A few words about synhaloring, which is a natural structure supplying the optic nerve head with arterial blood flow. Usually this is segmented, not in all cases. This can be picked up very easily. This is a no problem case. This is normal. In contrast, there are many abnormalities artifacts. This is an advanced glaucoma case with a very severe bundle defect, but at the same time, a vitreous floater imitates another nerve fiber bundle type defect. This is the most sensitive part, to my opinion, of OCTA. You have to control everything for vitreous floaters. This case and the others were mentioned when we have healthy persons, no systemic, no topical medication, otherwise healthy eye, very high pressure, no advanced glaucoma, and you very significantly reduce intraocular pressure. In my case series, it was at least 50% reduction down to 18 millimeter of mercury or lower. Then the perfusion changes dramatically, very significantly, because these eyes are able to recover from the high pressure stage. And one case report about progression, this was published recently in Journal of Glaucoma. This is a person who participates in my long-term perspective study, imaged every 6 months. And this eye was not controlled sufficiently for IOP. The patient didn't agree on intensification of treatment. And what we did see was a significant thinning for retinal nerve fiber layer, for GCC, a significant worsening of the octopus visual field with trend analysis, and at the same time, for the total peripapillary area, there was a significant decrease also with trend analysis, and they were pretty much alike. Altogether, OCT angiography is very useful to detect various abnormalities in and around the optic nerve head. Use of OCTA is not alone method. It should be considered always together with the complementary information pieces. But OCTA angiography results are not specific for any disease. Therefore, a proper clinical evaluation, which is so frequently missed nowadays, is mandatory. Thank you very much for your attention.
I'd like to invite all the speakers to come up to the front. Sorry, sir. Your question, please.
My name is Dr. from Pakistan, and I am one of the Optovue users. My first question is, does the macroganglion cell changes appear earlier and at the level of the optic nerve fiber layer? Now, traditionally, we take the thickness of the nerve fiber layer of the optic disc head. So do the changes at the macular ganglion cell complex, they appear earlier than the changes at the level of the optic nerve head?
From our results, it seems that you need to use both, because in some eyes, the nerve fiber layer defect appears first, and in other eyes, the macular ganglion cell complex defects appear earlier. So you need both to be able to catch early changes.
My second question was that what is the diagnostic importance of the focal loss volume and ganglion cell loss in glaucoma suspects?
I think it is the most specific indication that there is glaucoma damage. In that, if you have a overall thin nerve fiber layer or overall thin ganglion cell complex, it might be due to you're being born with thinner eye structures. But if you have focal loss, that really cannot be due to natural variation, but it must be due to a disease process like glaucoma. And I think that's why it's so predictive of later conversion and progression. Thanks.
If you don't mind, I also would add to this. We published a paper some years ago in Journal of Glaucoma on that, and focal loss volume and global loss volume were the most sensitive parameters for progression. This is actually that long-lasting prospective study for which we have published many papers, and so that is the most sensitive thing. However, it does not provide an information to you on the magnitude of the change. This shows, just like pattern standard deviation in visual field testing, that there is something going on, but whether it is clinically significant or not, you will not get an information out of that, so you do need to deal with the mean values as well. Because the mean values provide the clinical value. All glaucoma patients progress. that's not possible to stop progression. But one more word on that, be very much aware of the vitreous floaters. They can imitate progression. With aging, with follow-up, you have a higher probability to see more and more vitreous floaters, and they definitely increase the inhomogeneity in the macular area and may imitate glaucomatous progression.
Yes, please. Microphone?
When we're looking at,
When we're looking at progression on OCT, there is something like a change in both the retinal nerve fiber as well as in the ganglion cell complex just by mere age. So if, and also by the amount of intraocular pressure, like Dr. Hollow just showed us, that with higher pressures, you have lesser vessel density, whereas with lower pressures, your vessel density increases. Similarly, when you are looking for progression, is there something like an age-related, amount of decrease in the retinal nerve fiber layer or in the vascular density per year of age? Say at 60 you have this, at 70 you have this. So do you take that into consideration when you're looking at progression?
Thank you for this question. And what I have to tell you that OCT angiography has been available for 3 years. So this is not a meaningful time for aging. You are correct. Currently, there is no answer to that. And I think there are so many co-founders which all must be considered. And I think aging is the least important in this short-term clinical use we have. Intraocular pressure is also important, but in my study, that was a kind of proof of concept study. It's much more complex. I cannot tell you a number to correct for each millimeter of mercury difference. That doesn't exist. And I'm not sure whether in advanced glaucoma, this kind of compensation works. Needs much more work on that. Plus, never forget that while you are aging, you will have more and more vitreous floaters, and they do cause shadows, which are, I think, much more important than aging or actual intraocular pressure on treated eyes and so on. That's very, very problematic, and many images must be ruled out from research studies because of the small shadow effect.
in clinical practice, would you want to make a baseline OCT at a reduced pressure or at the pressure at which you start treating the patient?
That's a good question once again. I would do both. And I think that in most cases, not for research, but for clinical decision making, you will not find too much difference. For example, signal strength index. That is a much more important stuff in comparison to anything else. And cross-sectionally, when you take an image right now and take an image 10 seconds later, the measured perfusion parameters are different according to the signal strength index. The higher index you have in the well-accepted range, the higher the measured perfusion. So this is not so easy to clearly answer.
Let me just add a couple of results we know pretty sure. One is that there is aging change. In round number, about 0.2 microns per year for both GCC and nerve fiber layer. It's small, so that if you compensate for it, you will get a small effect in terms of progression detection, but it's not a big effect. The measurement variability, is probably dominant. If you do this analysis over a few years, it's not an important effect. And intraocular pressure seems to have an effect when you study a large group, but on an individual basis, the effect is noisy and unpredictable. So, and it's again a small effect. So I would actually not worry about it as much. The biggest thing to take care of is the signal strength. So if you have a poor signal strength scan, you might want to redo the scan, recenter it, and put in artificial tear so that it's within acceptable range. That's probably the biggest factor.
Above signal strength.
strength is good enough? 8 and above signal strength is good enough?
8 and above. Chen Yuan, you want to talk about that? Yes.
Excuse me, one more comment. I think that when we measure ocular blood flow, usually we consider mean ocular perfusion pressure as well. Blood pressure, IOP, all these things are extremely important. And this is my opinion. I think that we should apply these options to the OCT angiography in glaucoma as well. Do you agree?
This is important, but it is difficult to get at the same time. In my study, everything was measured practically in a very few minutes time span. So first, obviously for image quality reasons, OCT and OCTA were taken, then immediately pressure and blood pressure. But this is not realistic in routine clinics. And even if there is a 15 minutes, 30 minutes different, you cannot really use that blood pressure value to correct for the OCTA.
In terms of OCTA, we have tried a number of measures, flow index and vessel density. And with flow index, you can actually get physiologic provocations that change it. For example, breathing oxygen, visual stimulation. And so it can change from time to time, whereas vessel density is a lot more stable. So for that reason, even though a lot of people are very interested in flow index as a more pure measure of blood flow, I think for diagnosis, it's actually cleaner to use vessel density, which is not as affected by physiologic states. So I hope that answers some of your question.
One more question. On OCT angio, the inferior macula is the earliest one being affected. Anything with the inferior macular vascular supply? As Dr. Natalia was showing that this is the inferior macular area which is being affected, the first one. So anything with the vascular supply of that area. You follow me? On the ganglion cell complex analysis, this is the inferior macula which is going to be affected first. Mm-hmm. Is there any relation with the vascular supply of that area?
Thank you for the question. You see, we suppose that, yes, there is a relation between structural and loss and vascular density. But I should mention that it depends on the stage of glaucoma process. You see, for example, at the beginning of the disease in early glaucoma, we observed the irreverse correlation, for example, between the vessel blood flow in the ophthalmic artery and vessel density in macula, the irreverse. Then it was direct, but at the beginning, the more blood flow came to the eye, the less vessel density we obtained. So there is a lot of questions concerning the pathophysiology using this method.
I think it may be more likely that the macular vulnerability areas actually arise from the structure of the optic nerve head, whether it's mechanical or vascular. We're not sure, but that the origin of that is probably in the optic nerve head.
Hello. I'm not a glaucoma specialist by background. I'm the head of diagnostics in Helsinki, and I've been doing quite a lot of macular imaging since 2008. Back in those days, I originally started thinking about these, what I call bites from the donut, which kind of correlate to the losses in the circular thick area in the macular zone. In that period, there was a lot of talk about AMD, and obviously this was not AMD. But in the past 10 years, since I've been looking at these cases, I never saw particularly strong connection to IOP or necessarily in a large number of the cases a connection to peripheral visual field losses. I'm a bit worried that we might be, there's a chance that we might be going into territory where there might be a subset at least of macular microvascular disease which has the danger of being sucked in to the sphere of being nominated as glaucoma, even if we are actually talking about something local, something specific to the macular vasculature itself. Of course, patients with general microvascular disease are, of course, liable to get many types of microvascular problems, both of the optic nerve and the macula. The risk factors are the same. Could you elaborate on the level of discussion that is going on to make sure that there is enough care taken that we retain the kind of the purity of the diagnosis of glaucoma and don't try to mix diseases, family disease, disease families?
If I may start answering, I have a very clear rule which I mentioned today and mentioned yesterday. Proper clinical examination first, imaging is a possibility second. If imaging is used to screen people, that is hopeless. I very clearly specified now and yesterday as well that imaging cannot tell you what is the disease the patient suffers from. That is not a disease-specific technology, whatever imaging is. First of all, if you want to deal with a macula, you need a macula specialist or a medical retina person. If you want to deal with glaucoma, you need a glaucoma expert. You cannot use any instrument or groups of instruments to identify glaucoma without clinical assessment. You can identify something outside normal limits, which is a statistical issue. But from them, just because glaucoma, whatever, pays better or more sympathetic or whatever, you cannot classify patients clinically.
And I should emphasize that now we are at the very beginning of the investigation, I think, in this area, and maybe it will be more useful for some understanding of pathophysiology before the clinical practice. I think so.
So glaucoma is characterized by damage to the disc. So your clinical optic nerve head examination will be very informative in terms of distinguishing glaucoma from other diseases. And glaucoma damage you should be able to trace from the disc rim, whether by clinical exam or OCT or OCT angiography, to the peripapillary nerve fiber layer, and then to the macula sometimes if the trajectory follows. And so you have to, I think, look at all of these regions in order to distinguish glaucoma from some other possible disease, such as diabetic retinopathy. And of course, correlation between the structure and the blood flow and visual field also give you more information. So I think by looking at the whole picture, I think most of the time we actually probably don't have a lot of doubt on which disease it is. So we certainly are not advocating to use any one of these new technologies by themselves.
Anyway, I see a lot of danger here. I see a lot of patients that have been, individual patients that have been characterized as glaucoma, even though they do have other type of vascular disease. This happens in clinical practice. So
Actually, the general ophthalmologist should be very careful about that, and not glaucoma specialists. We do see a lot of misdiagnosis all across the disease spectra. So this is very unfortunately no new information, I think.
That's a rare disease problem, right?
So, do you have a question? Can I?
Sure. One final question.
Oh, thank you. So, hi everybody, it's a pleasure. It really was a pleasure to hear all of your lectures. Actually, you answered my question in advance about the flow index and about using the vessel density parameter. But you said something interesting afterwards, and this is that the vessel density is much more robust and stable parameter. And what you, Gabor, did is you decreased the IOP, and then you used the vessel density parameter, and it improved. But before you answer, just to ask another question, and this is the following. It is interesting that if you use a flow index, I would like to know actually how it's calculated, but this is less important. The more important thing is if you use oxygen, if you use cold pressor test or flicker or whatever, you can see the change, the quick change in the flow index. Is the explanation of vessel density change after the reduction of the intraocular pressure, the recruitment of the new capillaries? And then immediately the next question, if you use only the vessel density change, you will actually be limited only to measurement of the IOP change effect on the blood flow, and you will cut the possibility of, let's say, investigating the calcium channel blocker effect or other effects on the functional change of the blood flow. So I would like to get a sense on this, please.
So the flow index is calculated by multiplying, averaging the flow signal, which is decorrelation values, and that is nonlinearly related to flow velocity and vessel caliber. So it's a complex composite that has that should be correlated with flow. And we actually we didn't find that it correlated with blood pressure or intraocular pressure, although it does can be modulated with visual stimulation and oxygen breathing. So we do have a trabeculectomy study where we dramatically decrease the intraocular pressure in glaucoma patients, and we found actually no short-term significant change, but after 6 months, there is increase in vessel density and flow index, possibly due to remodeling rather than instantaneous or quick response. Maybe a little bit different result.
Well, that's a different design. That's a different question, different answer. When you do trabeculectomy, this is usually, in good case, not for fun. You have established damage. You have usually at least moderate glaucoma damage or severe glaucoma damage. And then the reversal capacity is already lost. What the cases I had, these were consecutive cases. Healthy people, no systemic medication, no topical medication, clear optic media, but they were either ocular hypertensives or pigmentary dispersion cases. There was one pigmentary glaucoma in early phase. They still had the capacity to recover from the provocation, which was the high pressure. And this is not necessarily the case, or typically not the case, when you go for more advanced disease stages. In addition to that, I definitely did not include any cases with surgical intervention, because surgery alone may definitely intervene with the imaging, the refraction, the lens clarity, other factors. And for my study, which was in fact a proof of concept study, very first in this respect, I wanted to have a clear situation, but in real life, all these things mix up, and I am not so optimistic to see a consistent change, or to foresee a consistent change in such cases.
Well, thank you all for staying so late, and I'd like to thank all the speakers.
Can I have a last question, please?
Do you have time for that?
I'm a general ophthalmologist from the Netherlands and studying glaucoma patients with GTC since a few months. Can you tell me what is the influence of the existence of an epiretinal membrane on the GCC?
That depends on if the segmentation is accurate. Epiretinal membrane can interfere with the measurement of GCC thickness because the software that detects a boundary of the GCC can mistake the epiretinal membrane as part of it. So if you detect that, if the epiretinal membrane is present, you may have to check the OCT section and the segmentation to see if it's accurate. It might introduce an error.
Okay, thank you.
And even if the segmentation is okay, there could be a pulling effect. And that could increase, not tremendously, but somewhat, the inner retinal thickness, just because of the pull effect. So you have to consider the clinical picture. Once again, classic clinical evaluation is everything. And then you can refine for more details with the technology.
Dr. Joe, do you have any tip?
So basically, in those cases with retina pathology, you will not rely on GCC only. You will still go over to the peripapillary region to look at the nerve fibrillary or look at the disc.
If you have abnormal GCC and a normal ONH, does it tell you anything?
Abnormal GCC and normal ONH,
On OCT?
usually that kind of indicate a relatively earlier change, and it's limited to the macular region because I will look more closely whether the nerve fiber layer is slightly thinned in the temporal sector, which corresponding to the GCC area, and the nerve fiber layer, the peripapillary region, obviously cover the entire ganglion cell population. So it's not a one-to-one correspondence.
Okay, thank you.
But the main rule is that you have to see some spatially corresponding GCC change and retinal fiber layer change, even if they are within the statistical normal limits. If you do see a major discrepancy, this is an indicator of an artifact.
Thank you again.